Hello. Well, thanks for the opportunity to share some of our recent clinical results and to talk a bit about photonic cataract surgery and robotic workflow innovation, or integration, excuse me. When it comes to photonic cataract surgery, it kind of starts for us with photoemulsification, and we have a technology called the femtomatrix, which allows us to modify the wavefront of the laser beam to create multiple spots, shaped spots, and enable new ways to perform the surgery. That allows us to take the inhomogeneous cataract lenses of all grades and turn it into a homogeneous volume of small cubes, 200 micron cubes, that can be directly aspirated without ultrasonic energy. And one of the technologies we have there that I'll talk about is our threshold scanning system. It's a way to determine the laser threshold throughout the volume of the lens, which allows us to have the energy set for minimum gas and best incisions. In addition, we have robotics integrated into this system. It allows us to do either semi-automated or fully automated docking. And OR integration, right now the patient and the doctor move to the technology, and we believe the technology should move to the patient. So the robotic arm allows us to share the same workspace with the surgical microscope, and there's fluidics and phaco integrated inside as well. In terms of recent results, we just did a pivotal study, so we have safety and efficacy data that we can submit. We have an interesting new operating regime for this surgery, which I'll show you. And I think the term FLACS, femtosecond laser assisted cataract surgery, kind of describes the current state of the market. We believe it's time to turn that around, where laser cataract surgery becomes the standard and phaco is an assist technology. So in terms of what does this look like? So on the left is a sort of conventional laser fragmentation pattern. It was done in one of our studies. Dr. Stadulka does bilateral cataract surgery, so we were able to look at our laser and the Victus and phaco. And you can see it's basically a pizza cut. There's a lot of gas there, and that's kind of typical. Requires a lot of phaco to get that lens extracted. In the middle was an intermediate photoemulsified lens. You can see all the cubes. These go through the entire volume, and that worked well. And on the right is a more recent version where we stagger the different layers and we have some different parameters, so we're able to continue to increase the efficiency. Bottom left is how we measure a threshold. That's an image that shows a series of spots of different energy. The OCT system can then image that and find out what is the threshold energy in that particular lens location. Allows us to optimize the cut throughout the volume. In the center bottom there is just a graphic showing we have a phase mask technology that changes the wavefront of the laser to allow us to have multiple spots, shaped spots. And on the right is the cubes that we create inside the lens. So here's a video I'll play for you. This is one of our recent cases. We have a multiplane entry incision, capsulotomy and photoemulsification. He just did a visco injection there that dislodged the entire capsule and now can actually just aspirate the capsule directly. That's how nice and clean they are. This is a grade 2.5. There's no ultrasound energy used, although that is a phaco tip because we like the large diameter to make the small cubes easier to extract. Now he's going to rotate the lens, and you'll see as soon as that cannula gets into the photoemulsified volume, it all just starts to come out very quickly and easy, like a real fluidic aspiration. So that was about a 26-second aspiration of a 2.5 grade nucleus. In terms of workflow integration, it's very interesting. So you can see the surgeon, Dr. Stadulka, sitting in the center. Right behind him in the back is the robotic arm of our system, and to the right is the surgical microscope. So this is sped up, obviously, but you see the robot comes into play. This is a semi-automated docking. So he docked, he finished the procedure, the system goes back home, and the surgical microscope comes in. Here's a close-up of him docking. Very simple, very easy to automate, we believe. You can see in the background the procedure going. I'll just move ahead. Whoops. Can I go back? How do I go back? A quick review of everything. Sorry. So this slide's a little busy. Take you through real quick. On the upper right shows the progression of Dr. Stadulka's time. Time was never an endpoint in our studies, but nonetheless, he got 67% faster in aspiration. Lower right shows an interesting, the gray is kind of the literature-based operating regime of speed versus phaco energy, and they kind of trade off. The pink is where our clinical data is, so we believe we're going to be able to get faster and faster and faster with very, very little ultrasonic energy. And on the right is the cumulative dissipated energy in there, and you can see we're in a different operating regime, so we think that's going to be a big advantage moving forward. Thank you.